Okay, so whilst we're just waiting for the numbers registrants to keep climbing, my name's Dr. Viraj Barambi. I'm one of the consultant neurologists at the Walton Centre in Liverpool. This is now climbing as the number of Global Health Network sort of sessions that we've done. And I'm quite pleased to say that we've got funding and approval to carry on doing these for quite a few more months, which is great news. We've got an excellent sort of hour lined up today. We've got the whole hour sort of dedicated to movement disorders. I'm in a moment going to introduce, in fact, I'll do it now. I'll introduce Dr. Sundus Alusi, who is a consultant neurologist at the Walton Centre in Liverpool. Also, she subspecialises in deep brain stimulation, tremors, and Huntington's disease, and she was a clinical lead for movement disorders at the Walton Centre from 2020 to 2022. So, Dr. Alusi, if you want to take over and introduce the panel for us.
Thank you very much, Viraj. Good afternoon, everyone, and thank you very much for attending. We hope to be able to deliver a good session. I'd like to introduce our speaker. This is Dr. Nestor Nsengiyumva, who is a consultant neurologist at Burundi. He did his training, his basic training in Burundi, as in schooling, and then got a scholarship to train in Russia, and did his medical and neurology training there. We were lucky to have him as a fellow, as sponsored by the MDS, International MDS Society, and now he's practicing as a consultant neurologist. Welcome, Dr. Nsengiyumva. I'd like to also introduce one of our panelists. It's my pleasure to introduce Michael Bonello, who's also a consultant neurologist here with us at Walton Centre. Michael studied his specialist training in neurology at Walton Centre and did further studies, further fellowship in movement disorders, again at the centre. He also did, he has good experience in neurogenetics and did his master's in that. Welcome, Michael. Okay, so Nestor, we are very pleased to hear that you're talking to us about Parkinson's disease in Africa. Please share your screen.
Okay, thank you very much. Let me just share my screen. Hello, everybody. My name is Dr. Nestor. I'm one of the neurologists in Burundi, as introduced. I'll be talking about the management of Parkinson's disease in Africa. So I'll be mainly talking about, I will just have an overview. I have nothing to explain about Parkinson's disease. I will just do an overview of Parkinson's disease, and then I'll present a clinical case. And then I'll present the challenge of the management of Parkinson's disease in the setting of low-income countries, especially in Africa, and then I have my conclusion. So as we all know, Parkinson's disease is a neurodegenerative brain disorder that affects millions of people. And I think the important part is that it's a progressive degeneration disease. And this makes it as a progressive disease, this makes it difficult then for patients, because with time, we have to see those motor fluctuation and its dyskinesia, which come from this progressive neurodegeneration. And also, I have to mention that because of this progressive neurodegeneration, there's no single drug that has, unfortunately, firmly established as disease modifying or neuroprotective. We all know that the factor that determines therapy are patient's symptoms and age, stage of the disease, degree of functional disability, level of physical activity, and so on. And we do have our levodopa-based treatment. And we all know that levodopa is the #1, the first-line symptomatic therapy in all patients with Parkinson's disease, with dopa agonists and MAO inhibitor and amantadine, depending on the specific features of the patient and the stage of the disease and so on. We also know that I think there's an important question: when should therapy be started? And of course, the timing is determined by the degree to which the symptoms interferes with functioning and impair quality of life. Some of those factors then is the effect of the disease on the dominant hand, the degree to which the disease interfere with the work, activities of daily living or social leisure function, the presence of significant bradykinesia or gait problems, and the patient value and the preferences regarding the use of medication. Of course, there is a fear of starting levodopa because of the reported association with motor fluctuation. And I think it's important for every neurologist to explain the natural progression of the disease as PD, because as PD progresses, studies have shown that the dopaminergic neuron continue to degenerate, and then they lose the ability to store the levodopa after the synaptic, to store the levodopa after enzymatic conversion to dopamine, and then which will result in decreasing response to exogenous levodopa. Of course, this will be important in the setting of Africa, because we will see that one of the many problems in Africa is that people diagnosed with Parkinson's disease and even with other neurological disorders, they don't come for follow-up. Although we know that this is a progressive disease that will get worse with time, and then with the motor fluctuation that we know that they have to occur over time. Well, we know that besides the medication, we have the education to support the nutrition, the exercise, and other non-pharmacological treatment. So that was a 70-year-old man who presented to our clinic with the tremor. The tremor was worse on the right than on the left, and he also has difficulty with the balance. So on the examination, of course, there was slowness of the movement, the speech was monotone and low, less facial expression, and the tremor was resting in the rigidity, and really nothing to challenge the diagnosis of Parkinson's disease. It was obvious, the diagnosis was obvious. Then I started carbidopa levodopa, the 2500 milligram, and then 3 times a day, and then instructed the patient to come after a week to adjust the dosage, the dosage depending on the response and yes, depending on the response. So this patient then, from that time, I have never seen him. So one may think that maybe the patient went to see another neurologist. I would say probably no. As we talk with other neurologists, we all agree that really patients more likely will not respect the follow-up. People usually, people will visit the doctor here in Burundi and maybe in many countries of Africa if there is something that's very painful. If there is a painful situation, for example, there is pain, then they feel the need of consulting a doctor. So, and the main problem here, as we're going to see, is that there is a belief that as Parkinson's disease happens in old people, there is this belief then that it's just part of the normal aging, which is of course wrong. Let me just talk about the challenge then in managing Parkinson's disease and other movement disorders in Africa. So first of all, we have the problem with the initial diagnosis. People will come, most of the time they will come at later in the disease, because they will see the tremor, so they just think that it's part of the normal aging, though nothing to worry about, and it's not a serious problem. Of course, there's also the financial issues that we're going to see, and also, as I said, there's that challenge of follow-up. There's that challenge of follow-up, but mainly the unavailability of the treatment, of PD treatment and services and drugs. The other problem is also, yes, as I said, we know that patients should be evaluated for levodopa response and the adverse effect at each visit in effort to optimize the response and quality of life. And again, as I said before, there's that problem of further visit because of the belief that the disease, we know, is just part of the normal aging. Yes. So then there's that the problem also with the unavailability or let's say the postgraduate training program neurology for neurologists is lacking here in Africa, as you know. And there is a study that we did last year with colleagues from different parts in Africa, and we found that fewer than half of the countries have established postgraduate training program for neurologists. And I think this is an important part. For instance, here in Burundi, we are 7 neurologists across the country for 12 million people. So that's another issue. And of course, we are not talking about the training in movement disorders. If there is no training in neurology, how there should be training in movement disorder? I think this makes sense to everybody. So, well, I would say that the main concern, the main gaps, maybe actionable gaps, if you would like, the pure understanding of neurological diseases, and there is this cultural aspect, the belief that those diseases, especially occurring in old people, are just part of their normal aging. There is, of course, this unavailability and unaffordability of the specific treatment for Parkinson's disease and the services related to Parkinson management in African countries. And of course, the absence of the formally structured postgraduate education and training in movement disorders for neurologists and other allied specialists. So I would say that what I've seen really, not only for movement disorders, first of all, I would add that people, Parkinson's disease, like other other neurological disorders, they are mainly managed or dealt by general practitioners because of this lack of qualified neurologists across the country. Well, there's also, of course, this lack of understanding of the diseases, the belief that some of the diseases happening in old people are part of the normal aging, but also diseases like epilepsy, when people see someone shaking, doing those tonic-clonic movements, contraction of the muscles, then people just be running, saying that, you know, those are maybe natural forces. So there's really a big job here for us and for the government to make people understand some diseases, especially neurological diseases. Thank you very much.
Thank you very much, Nestor, for this lovely comprehensive talk about the causes. And now, before we go any further, I'd like to introduce Dr. Dan van Wielen, who's joined us now on the panel. Thank you very much, Daniel. So thanks, Nestor. This is really nice. And I just I'll start by asking you really before we take any questions, if you don't mind. I mean, you've really nicely summarized the hurdles with to follow up, mainly with chronic movement disorders. Follow up is key, as you said, and you know. So some of it is cultural, as to probably they're coming for one-off antibiotic dose to take the problem away, and this is chronic and requires regular follow-up, and financial, I'm sure, as you said, and also maybe cultural sort of restrictions in terms of poor capacity really for education and availability of services. But you've summarized it really nicely, and I'm sure there are other factors that you will see daily that you haven't mentioned. I'm happy to take any questions, and we'll ask. Are you happy, Nestor, to be asked any questions?
Yes,
yeah?
For sure. Yes.
Okay, all right.
Thank you very much, Nestor, for that brilliant presentation. I think it's hugely informative and gives some insights into the challenges you face dealing with movement disorders in your setting. During the registration, we had some questions come in. So may I ask to yourself and to Dr. Alusi, do you have any input on the approach to movement disorders secondary to medication? Is this something you see, and do you have any comments on the management, for example, tremor secondary to lithium or Parkinsonian effects after medication? Thank you.
Thanks, Greta. All right, Nestor.
Yeah. So I want to make sure I got the question. So the question is asking the treatment of movement disorder related to medication, right?
Yeah. Yeah.
So I think that will depend on the types of disorders, why the medication was prescribed. And then we all know that, for example, the antipsychotic are one of the class of the drug that will cause the dyskinesia or other movement disorders. So, and we can, one option is to switch to a drug in the same class known to be better than others as regarding the movement, the side effects. And of course, depending also the reason why the medication was prescribed, maybe if those side effects are really troublesome, are really bad, and they limit the functioning, the daily functioning of the patient, maybe we can opt to take off that medication.
Thank you, Nestor. And before I go to the panelists as well and see if they have comments, I mean, one thing that is happening here and I guess UK and other developed countries is that you have liaison with psychiatrists regarding those medications. And as you said, if they're mentally unstable, you know, the last thing you want to do is to. So my question to you, Nestor, really, I mean, you've told us about the sort of unavailability of movement disorder clinics. So what about psychiatric clinics? Will you have that facility to even liaise with them? And do they present? I mean, if they don't present with Parkinson's, are they going to present with schizophrenia to the medics?
Yes, that's true. So if, by instance, here in Burundi, we do have one center for neuropsychiatry, and I'm not sure how many psychiatrists we have, but you know, there are few of them, and fortunately, there is a policy to send for specialization, and I guess this year 15 a young doctor has been selected by the government to be sent for specialization in psychiatry. But I don't think we have 5 psychiatrists across the country. I don't think we have such,
Yeah, thank you very much. And the panelists, any comments on what's been said so far?
Yeah, one of the things I would say is that sometimes I think Nestor makes a very good point in trying to change medication to try and find something that's less neurotoxic sometimes. So, but a lot of there's a lot of restrictions, is it, with finances and identifying that right medication. So you might know that the patient might do better with, say, quetiapine, for example, rather than haloperidol, to improve their physical side effects. But I'm not sure what the availability of such drugs will be in various countries around the place. I know, for example, for certain, when I went out to Zambia, we didn't really have a lot of antipsychotic medication apart from those were really restricted. So sometimes it can be quite restricted from that point of view. If you're really restricted and you know that the patient needs, say, your antipsychotic medication such as procyclidine and other anticholinergics can be used to try and help things like certain types of movement disorders. So yeah, sometimes it's just about trying to being a bit creative, but also trying to use the least dose required. Really is the one thing I would add.
Thank you, Michael. Daniel, any comments you would like?
No, I think I just want to say I agree with everything that's been said. I think it's a very good step to obviously see if you can switch to something else, if that's obviously available within, kind of within the resources. Also, the low dose that was mentioned, I think, is a very good idea. I mean, sometimes even perhaps it depends on the situation. You could consider stopping medication altogether, but then obviously you might run into other issues. But I think that everything that's been said is a very good practical approach to this.
Yeah, thank you very much. I mean, Nestor, I know you didn't mention it, but you have published with a group of authors about Parkinson's in Africa, and I've read that because you've sent it to me. Thank you very much. And it says that even levodopa is not available in, I can't remember the percentage of countries, and shockingly, bromocriptine is used now in the UK, and I'm sure all over Europe and the US. That's no longer used because of the severe associated side effects on cardiac and retroperitoneal fibrosis and all sorts, really. So I'm surprised that, well, I'm not surprised, I guess, but maybe it's cheaper, but it's prompted me to go and look up the cost of levodopa, and in the UK is £3.49 or something for co-caraldopa. So I don't know why is levodopa, I mean, I don't think it's more expensive than bromocriptine, or is it? It's certainly a better drug.
No, for sure. Obviously, we are talking about across the year how available is the drug. If there's any shortage or not, that's what the percentage was all about. And bromocriptine is just available for the other reasons that we use in medicine, like the suppression of lactation after, for example, loss of baby, and so for other reasons, medical reasons. So nothing to do with the Parkinson disease, obviously.
Okay, so short use in stopping lactation is probably not as harmful as lifelong Parkinson's treatment. So it wouldn't be recommended for any country really to use it as first line. But thank you for highlighting that in the publication. Okay, are there any questions?
Yes, yeah, Dr. Nsengiyumva, we have a question from a Dr. Campbell. I think he'd like to ask it himself. So if you wouldn't mind unmuting, Dr. Campbell. Okay, all right. That's right. I think. Yes, wonderful. Do you want to ask your question?
My question was about the possibility of doing postgraduate certificates. or diplomas in neurology in a kind of horizontal articulation, if you will. So it's a step up. It broadens capacity of the existing general practitioners, and it's more affordable than a full postgraduate specialization.
So I'm not sure if I got that right, but are you saying that it is possible to do a shorter diploma or a short course in movement disorders rather than a full postgraduate training? Is that what?
Yeah, so I think
that's what I would propose. That's what I would propose as the to broaden the capacity of the existing GPs
Yes.
to do a postgraduate certificate, and also perhaps to broaden the existing education system to step up to building those courses for full specialization.
Yeah, absolutely. And actually, the so-called developed countries could provide online free access to so many of the courses that people can join from their countries, like Nestor's joined us now. Yeah, and provides X number of seats. Well, it doesn't cost anybody to provide it, but it's a matter of promoting that. And that's exactly the reason for holding these meetings, really, is to promote networking and education. And I think that's an excellent suggestion. Yeah, thank you. Any other questions?
Yeah, I do have a question. I think as well as the training of your personnel and your human resource, one of the big problems is kind of access, distance to services, and the fact that people will have to pay out their pocket to try and get to you. And so by extension, I can see, a comment in the chat from Dr. Bonello. To what extent is it possible to do some remote management, to contact people by phone or do videos to manage movement disorders such as Parkinson's in Africa?
Yes, so Nestor, what do you think?
Obviously, I'm afraid this may not be possible in most of our settings for really many reasons. First of all, see, let's say there are 7 neurologists in the country, so people are very, very busy, and I don't think to be really possible to follow up. I mean, patients across the country at a distance. And probably the other problem is the understanding, the knowledge of the background knowledge of the populations, to be able to explain the symptoms and to make sure that you get their point really at a call, at phone. So I think there are many reasons that make this just unpracticable in our settings.
Yeah.
Hello?
Yeah, although some countries are providing that, actually. I think I certainly was asked whether, I think it was Egypt, whether, I would be interested in providing online, if you like, consultation to patients from there. So it would be your general physicians rather than neurologist, or maybe GP. I don't know if you have a GP system, actually, but the general doctors can access, because you, from what I understood from you, Nestor, is you have to do everything, don't you? Stroke and everything. It's a very busy thing for your neurology.
Yeah, so if you're a neurologist in a country like Burundi, so you are stroke expert, you are epilepsy expert, you are inflammatory diseases expert, you have to do everything. You are not referring to any, like, let's say, expert in epilepsy or movement disorders or in myasthenia gravis. So you have to deal with everything.
Yes, yes, and that puts pressure actually on the
Hello?
practitioners. But thank you, Nestor.
Hello? I have a question.
Brilliant. Thank you. Put that to the panel.
Go ahead.
Hello.
Yes, please go ahead. Is that
Thank you.
Zain?
My name is Honorary. It is assumed that anti-Parkinson drugs, especially dopamine analogs, can enhance the tendency of gambling and also enhance the sexual activity. If it is yes, how we can avoid to these unwanted side effects?
Zain, can I just understand that clear? So the Parkinson's medications can enhance what? I beg your pardon? Couldn't hear that.
Increase the tendency of gambling and also enhance
gambling,
the sexual
okay.
activity.
Yeah, so impulse control disorder. I don't know if Nestor, you've seen that. So the dopamine agonist can indeed, and even levodopa, but much less extent. So it's depending on which study you look at, but it can be up to 14%, and I think in practice it's a lot more than that. So here we warn them about the impulsivity issue, and despite that you see a lot, and you try not to increase the dose beyond what's needed. So essentially you use it as an adjuvant to levodopa, if levodopa is available, that is, and you try and educate the person that they may feel impulsive, and if they did so, to stop it. And you know, and if they did that, to seek medical attention. But I don't know how that would work in Africa, actually. So firstly, do you have dopamine agonists other than bromocriptine? Do you have any of the non-ergot derived, and do you see impulsivity?
Yes, we do have them, but really you big shortage across the year. But I think what personally I would do in such case is, maybe, as we know that impulsivity, those side effects are more common with dopa agonists. So, and we know that one of the contraindication of using dopa agonists is actually the history of compulsive disorders. So I would maybe switch to levodopa and maybe try with low dose and see how it works. So yeah, thank you.
Yeah.
Thank you very much.
Perhaps
any comments?
can I add one thing to that?
Please.
Sorry for interrupting. Obviously, it depends on what's available. I do realize that, but there's some evidence actually to suggest that especially the longer working dopamine agonists, such as prolonged release, have a lower rate of impulse control disorders than the shorter acting one. So if that is something you can consider, switching an immediate release to a more prolonged release, at least for the oral dopamine agonist, that might be an alternative. And then, but again, it depends on whether it's available. Reticutin, for example, there's also some evidence to suggest that it has a lower rate of ICD and similar complications compared to the oral agonist. But of course, I realize it depends on what you have available, but that might be one other thing to consider.
Thank you very much, Daniel. Actually, that's a very good point. And as you say, it's the availability that's the issue. And I think it argues even more that some work needs to be done, WHO maybe level, to make levodopa available. It's a better drug, it's less side effects, and it really is the hallmark. It's the natural levodopa, isn't it, rather than replace it with man-made dopamine agonist. So I think hopefully this meeting and other similar meetings, this could be raised or networked somehow to try and see if anything could be sourced for the African countries that don't have levodopa, because I'm sure it would be cheaper than the agonist, although I haven't looked that up, but we have to see. Okay, any further comments from the audience?
Yeah, we have a question, sort of a two-part question, really. So the first part is deep brain stimulation involving the subthalamic nuclei working well with Parkinson's disease? And the follow-up from that is, what do you see as the future for Parkinson's management?
Nestor, do you want to answer that?
Yeah, of course, we leave this to Dr. Alusi.
Do you know, it seems a little, I don't know, ironic that we don't have levodopa and we're talking about DBS, but I guess we have to, because this is educational. You know, I don't want this to be unrealistic. Of course, the main main thing is to treat the patient with levodopa, of course, but once motor fluctuations start, which depending on the age of the patient, we're talking about anything between 5 to 7 years after in the younger patients, and maybe 10, 15 years in the older patients, motor fluctuations start to happen, and you're looking at advanced therapies. So yes, we would consider deep brain stimulation if there's no cognitive impairment or psychiatric issues. Now, how would that be available for countries like Africa? I'm really not sure, actually. I don't know, Nestor, whether you think there's any center that they could travel to and then remotely be managed from wherever the DBS is inserted. How does it work?
I'm not sure. I don't think there is currently any center where deep brain stimulation is done in Africa. So that's why I even said that I will leave this question to you, because we don't think about deep brain stimulation. And I think the cost of even sending someone to UK or any other developed country for deep brain stimulation is not worth it. Thank you.
Yes. So the person who asked, I can't remember who it was, actually. Sorry.
But we're not sure. It was one of the pre-registration questions, so I think it's just...
Oh, okay. So yeah, but I mean, it's an important thing to say that deep brain stimulation also requires follow-ups, and as Nestor demonstrated to us, follow-up is key in those movements. So that it's not a one-off either. So unless you do a pallidotomy or nobody does STN lesioning anymore for PD, but unless it's a research thing, but it's not a one-off, and it requires maintenance and battery placement and infections and bleeding and all sorts. So I think safety comes first, and unless there's a stable situation or stable contact with this DBS center, it's dangerous, in my opinion. Okay.
May I interject? I think there are a few centers in Africa who are doing deep brain stimulation privately, particularly I think South Africa, from my understanding, and of course, people might have a lot more. I think Nigeria, there are centers in Nigeria and Lagos and Egypt. But and regarding the treatment, as Dr. Alusi was saying, it's kind of one of those steps in the treatment where when we start seeing patients with motor fluctuations. So we know as the disease progresses, the medication levodopa, for example, might not be working as well as it does in the beginning of the disease. So you get motor fluctuations, wearing off of the medication. So patients take the medication, maybe it doesn't last as long. And that is when deep brain stimulation might be a good option. But it's not a cure, and it's not really, it does come with a lot of other things involved. And as Dr. Alusi was saying, it does require frequent meetings with the team, changes in settings, changes in assessments. There are side effects of stimulation, like gait problems that might need to be tackled. So that kind of follow-up is really important, and I think that is something that kind of one has to keep in mind. I'm just going to also point out to the future treatments of Parkinson's disease. I think personally, PD is a quickly developing area. There's essentially, we know that there's DBS, there's infusion therapy, so there's dopamine agonists that are given as subcutaneous infusions. There is levodopa that will be delivered as a subcutaneous infusion coming out in the future, and there is also pathogenic treatments targeting the pathogenic pathways, such as alpha-synuclein deposition, etc., that will be coming out in the future. So really, I would say watch the space. But yeah, we currently know that levodopa is really all of it is around treatment of levodopa at the moment.
Yeah.
Thank you, Michael.
Thank you. We've got lots of really interesting comments in the chat actually about availability of different services across the African continent, and I think it's easy to say Africa, and actually it's a huge continent with a hugely differential availability of care. And there are comments here about the availability of deep brain stimulation in South Africa and in some parts of Northern Africa. and the use of virtual consults for movement disorders. There's a comment from Rachel Fakili saying they definitely have it, DBS in Nigeria. And I think it raises a really broad point as well about inequality of access to neurological care and services. The fact that in some parts of, you know, the continent, you've not got levodopa and don't have long-acting dopamine agonists, and in other parts you've got deep brain stimulation. And Dr. Lucy raised the sort of important point about trying to reach equity and access to medicines. There has been recently a landmark WHO intersectoral global action plan on epilepsy and other neurological disorders. That it is really the first time that there's been such a big statement of intent for widening access to neurological disorders, recognizing the huge kind of mortality and morbidity of these problems, and saying, actually, you know, this needs to be thought of in the same way that we think of all these classic global health things like infections and malaria. Are actually neurological disease is so prevalent and there's huge morbidity and huge inequality in access to services. So I can see we've got a question. Youssef Nsengiyumva wants to put a question to Dr. Nestor. I don't know, would you be interested to unmute yourself and ask that yourself? I can see you've joined us. Would you, or I can put it to the panel. I'll just give you a moment. So I can see the question in the chat, and it said Africa does lack understanding of neurological disease and a lack of neurologists. What do you recommend should be critically done to make sure understanding becomes available for everyone and we increase the number of neurologists? So a question for the panel. Dr. Nestor, would you like to go first and then comment to your colleagues?
Yes. Actually, one of the things that we have been doing personally is some emissions on radio explaining as different aspects of different neurological diseases. I've been talking about the stroke and how it does manifest. I remember recently I talked about the unknown signs and symptoms of epilepsy, because people think of epilepsy just those shaking tonic or chronic movement, and they are not aware of other manifestations, and explaining also that it's a disease of the brain, not a punishment from the nature. I mean, so there is a way, like in conferences, through radio and things like that. Yes.
Thank you, Nestor. The other members of the panel, any comments about? It's a good point, actually, that raised that by Youssef. What could be critically done? I guess from Nestor's and his colleagues' point of view is more, yeah, as you said, more education through media, isn't it? But from us, actually, in the developed countries also, I think, as I said before, I think more trainees need to join really the training that is available here, and then they could disseminate the knowledge to their patients themselves. You know, you enable the trainees to actually get the knowledge to then hopefully disseminate to whoever they see as well in their population. Don't know if there's any other comments. I think there's a hand from Benjamin. Benjamin, please.
Yeah, thank you very much. And I appreciate the invitation. I want to include some aspects when it comes to management of movement disorders. You've been talking about the levodopa, carbidopa, and the deep brain stimulation. I think they are more of like replacing dopamine due to dopaminergic cell loss at the substantia nigra pars compacta. And the loss of dopamine apparently affects some motor function due to some electrical imbalances in the basal ganglia. However, there are several overlapping symptoms in other neurodegenerative diseases like multiple system atrophy and cortical-basal degeneration that presents with movement disorders, which definitely replacing dopamine via levodopa might not actually correct that. And we all understood that deep brain stimulation is invasive. It involves, discharging electrical impulses to some parts of the brain, and that can result into the patients not having the right treatments that he or she desires. So I was thinking, if you have inclusiveness of several scientists that has to do with understanding what the right cause is. In basic biology, we talk about alpha-synuclein aggregation causing cell death, talk about autoimmune disorder causing death of dopaminergic neurons or some neurons involved, some neurons of the brain involved in movement, and such resulting into movement disorders. But what we see at the clinic when it comes to diagnosis and management is when they see those symptoms of bradykinesia, like muscular rigidity, tremor, they administer dopamine replacement therapy like levodopa and carbidopa. And this tend not to be very effective. And we all understood that when we continuously infuse this dopamine replacement therapy, we could also have some other motor dysfunction like dyskinesia. So I was thinking, do we have a deeper, elaborate inclusiveness of molecular diagnosis, of biological diagnosis, to really understand what the basis of the movement disorder is, rather than just thinking it's dopaminergic cell loss, replacing dopamine or imbalance in dopamine metabolism causing electrical imbalancing, and we are invasively discharging electrons or electrical impulses into the part of the basal ganglia. And all this, because I actually belong to several groups where we have patients that have, they were diagnosed of Parkinson's disease, quotably, like they were diagnosed of Parkinson's disease. But they discovered that as the disease, they were given levodopa, carbidopa, and all that. But as the disease progresses, they discover that the levodopa is not very effective. And even with the deep brain stimulation, they still observe that the neurodegeneration continues and the movement disorder still persists. And this tends to give some kind of psychological, distress to the patient. So that was what actually led me into understanding the biological basis. And I saw there were a lot of underlying factors that might be involved in the movement disorders, which might not mostly be dopaminergic cell loss. It could be, autoimmune disorder, some kind of genetic diseases or kind of neuroinflammatory disease, which is not related to dopaminergic cell loss. So what do you include to be sure that before you start administering levodopa, carbidopa, or deep brain stimulation, as we've been discussing, that it's actually Parkinson's disease or electrical imbalance, which requires deep brain stimulation to correct? Because most patients will get disappointed if they have to go through all this surgery, therapy, and they're not seeing results.
Okay, thank you. Very, very good questions. Nestor, do you want me to answer? I'm happy that you have a go. It's about 30 questions, is it, Benjamin? But we'll try and answer some of them. Do you want to start, Nestor, or do you want me to start?
I think, yes, I will leave that to you, but I will just emphasize that Parkinson's disease remains a clinical diagnosis, and we rely on the symptomatology, the characteristic of the tremor, and the response to levodopa medication to make the diagnosis. And I think the responsiveness of the to levodopa, at least retrospectively, is part of the diagnosis of Parkinson's disease. But I will leave that to you, Dr. Alusi, and the other experts. Thank you.
I mean, you raise, thank you, Nestor. You raise multiple very good points, Benjamin. I think the basics is that this meeting was sort of more of a pragmatic patient management, but you're absolutely right. The academic side is also very important to answer those pragmatic questions. So two things to say really, in terms of is it chemical or electrical? Well, we now know that in the brain, it's both. So we no longer believe that it's just a deficiency of levodopa. You're spot on there. There's the whole neural network is disturbed, and this is how DBS works. So DBS does not release levodopa as such, but it actually reinstates the balance between those neural networks. So the first answer is DBS is not the replacement for levodopa, as Dr. Bonella was explaining, is to counteract the motor fluctuations, which are the result of the treatment, if you like, interaction with the receptors. So as you continue to replace levodopa after 5 or 7 years, then the receptors become hypersensitive or lost, and there's a very complex situation in the brain where chemical and electrical imbalances happened, and DBS has been found to readdress that. So that's one aspect. The other very interesting question you asked is about the Parkinson's plus and also the non-motor features. So we're in this lecture, we're talking about Parkinson's disease. We haven't actually touched, you quite right, on the mimics. So MSA and CBD and progressive supranuclear palsy. By all means, that really we should try and get Viraj to organize another lecture. And they're rare. So 90% of people who are presenting to Africa or to here will have Parkinson's disease, and that's why we chose Parkinson's disease. But of course, we can organize another talk for those. The third level of your questioning was actually the non-motor symptoms. So yes, you're right. Dopamine deficiency is only the motor manifestation. So the other features, the salivation, the autonomic dysfunction, the fatigue, the sleep disorder, the dementia is all not dopamine. You're right. There are many other neurotransmitters that are at fault there. We kept it basic really for, because this is sort of a short meeting and we're trying to address the main treatment. But you're right, when they start to have other things, there is a whole, may I guide you to, if you look at the NICE guidelines in the UK, I'm sure it's available online, and you look at the management of non-motor symptoms, it will not be levodopa. So for memory, you would use, cholinesterase inhibitors. For fatigue, you use modafinil or amantadine, and for sleep you use melatonin. So your question is spot on. We don't manage these with levodopa, but we were just talking about the basic motor triad of tremor, rigidity, and bradykinesia. But thank you very much, Benjamin. And actually, your academic interest is very, very welcome, and I'm so glad to hear you collaborating with others. Are you on studying this? Is that what you said?
Yes, and I think I have a placement if it's going to be sponsored at your center in January.
Oh wow! I look forward.
By the MBChB.
You make sure you have another 30 questions for me, Benjamin. I'll start.
I'm so delighted. I saw your resume, and I was like, oh, that means we're going to see each other if the MDS sponsor eventually. So I'm going to be under Dr. Antonella.
Yeah. Yes. Thank you very much, Benjamin.
That's great. So I'm going to be under Dr. Macerollo. I hope I pronounced that well.
Yes, Macerollo. Yeah. She's one of our colleagues here, movement disorders. Yes.
So if I have the sponsor in January, we'll be together.
We'll see you soon.
Yeah, thank you very much.
Daniel has his hand up for a comment as well.
Yes, thank you. I just wanted to make, I know that was probably not the aim of the meeting, but just one small academic observation here, kind of related to the comment that was made about the mimics. Obviously, we're always, very tempted to think, we need to classify people. Is it PD? Is it MSA? Is it CBD? But what I think is interesting, and we see that here in London as well, because we have a lot of people coming from sub-Saharan Africa, is that genetic-wise, there have been genetic variations described in the COMT gene, so one of the genes that actually breaks down levodopa into metabolites. So obviously, we're always very used to think, you add a decarboxylase inhibitor to levodopa that prevents the breakdown, but there's also the COMT pathway. I think what's interesting that, especially in sub-Saharan Africa, the variant that makes that COMT gene work faster It's actually quite common. So basically you give people levodopa, but they break it down very rapidly, with the effect, basically with the consequence that they don't have much of an effect of the levodopa, which then doesn't mean they have atypical Parkinsonism. They just have a genetic variation causing their Parkinson's disease to be more severe and be less easy to treat. So in that respect, it might sometimes be also worth to just go up with the dose, obviously, if you have that opportunity and if it's available. But just a small note I wanted to make on the side regarding the mimics in the genetics.
Oh, thank you so much, Daniel. We've learned so much from that comment, actually. Thank you.
Daniel,
of course, genetics as well.
Can I ask, Daniel, in that situation, would COMT inhibitors be an option if they are available?
Yes, that's something here, at least, we would definitely consider doing that. So yes, definitely, if you block that COMT pathway, in any way, everything becomes more efficient because you're basically blocking both pathways, breaking down the levodopa. So if you have that available, I think it would be worth considering that. Yeah.
And also, actually, Daniel, what do you think the researchers that are working on this, perhaps they could do, I mean, they will benefit to study, and also Africa will benefit from them sampling suspicious cases to analyze it and benefit them directly. So I guess the institution will benefit from studying, and the people of Africa will benefit from the treatment.
Yeah, I think that would be a great initiative if there's a collaboration set up, because obviously both parties will benefit. There's obviously the academic knowledge that will gain from that, but also it has a direct consequence because it might influence your treatment. And then you can also build probably the case in saying, look, we probably need to be slightly more aggressive here in terms of what we do levodopa wise, or perhaps as Michael raised, introducing COMT inhibitor if it's available. So that would be very useful if such collaborations could be put up, and really would work both ways.
Yes, excellent. Thank you very much. And this is what this is all about, isn't it, Greta? I mean, this is what we'd like to see, some sort of collaboration across the countries.
Yeah, absolutely. Like seeing people meet and have shared interests and kind of complementary knowledge and experience, and really we do have the possibility to set up research collaborations on the back of these meetings to try and seek external funding and form little working groups, and so please do contact myself if you have ideas and you think there's possibilities to form collaborations on the back of these kind of discussions, because that's something we're really keen to follow up and probably have some funding to do over the next few months.
Yeah, I mean, is May Anwar here? Is she one? So May, are you here? I thought I saw your name. So May is from Egypt, and she's been working with me about movement disorders in MS, actually. May, are you there? She might have dropped out. Who has a massive interest in that kind of work, not genetics so much, but biochemistry, actually. And she's been looking to represent Egypt, or indeed Africa, and work with the UK on a project like this. So I think she might have logged out. She was there in the beginning. I can email her. Thank you. Any more comments or questions? This is very exciting for all of us, actually.
I think we're drawing towards the end of the hour, and at least on a note of collaboration, we can draw things to a close with some hope, at least. So on the chat, everyone who's attended, there's a link for feedback. Any of your feedback would be really helpful to make sure that we do future sessions in a great way. I'd like to thank Nestor very much for an excellent talk, and thank you everyone on the panel for your time and fantastic insights, and thank you everyone who's joined us for your fantastic questions and for making it a great hour.